Hello, everyone, and thank you for joining us today for today's webinar, Overview of Screening, Assessment, and Brief Intervention, a Nursing Response to the Full Spectrum of Substance Use. I'm Tracy McPherson. I'm a Senior Research Scientist at NORC at the University of Chicago, and I co-lead the Brief Intervention Group Initiative, the BIG Initiative, which is co-sponsoring this webinar today. I'm going to be your webinar facilitator. The webinar today is produced in partnership with many of our partners who've made this possible. The BIG Initiative, NORC, NADAC, who is actually going to be helping us with facilitating the technical end of this webinar today, and also the National SBIRT AUDIT-C. We have just launched our 2014 SBIRT webinar series. As you can see, we have a full schedule lined up for 2014. We've already had one in January on ACA and addiction treatment. We hope that you will take a look at our website, hospitalsbirt.webs.com/webinars.htm, to listen to the archive of that, as well as to register and learn about our upcoming webinars. Of course, we have our webinar today for the month of February, focused on nursing, but coming up in March and April and on through the month of August, we'll be having topics around SBIRT and criminal justice systems, opioid risk with SBIRT, tobacco, and other very exciting topics around depression, tobacco use, and prescription medication abuse. So please join us and register for those upcoming events. These events are offering free CEs, and so we hope that you will take advantage of that. Also, on our website at hospitalsbirt.webs.com/nursingSBIRT.htm, which is here on the slide for you, you're going to find all the materials for the PowerPoints today that will be presented to you. This is also where you're going to find the archived recording of this webinar today. In fact, all of our archived recordings are organized on the website for any previous and upcoming webinars, and we put all the handouts and resources and CE information. Everything you would need for any webinar that you're interested in will be posted here. We are pleased to be able to offer a continuing education credit. We have 1.5 free CEs that are approved by NADAC and NBCC and accredited by the American Probation and Parole Association and accepted by OASIS. These CEs are free upon completing a quiz that we will be able to post. Actually, it's already posted to the website where you can access that and submit to get your certificate and your free CEs. The other group that we are able to offer CEs to today is the nursing professionals. We have 1.5 ANCC nursing continuing education credits. We are not able to offer those for free, but at a very minimal cost of $10. And it's approved through the University of Pittsburgh School of Nursing. You will also go to the same website, and you'll click on the link specifically for nursing, where you'll complete the form, and you'll be able to make payment for the $10. And in addition to that, I should mention that for the nursing credits, the credits are available for live attendance only, not for the archives, yet for all of these, all the education is free. So if you have colleagues who want to, you think should hear this webinar, they can still listen, but they wouldn't be able to get the nursing CEs. But on the other hand, for the other group that's looking for NADAC and NBCC, you can get credit for the archived viewing. And at the end of the presentation today, we're going to open it up for questions. For those of you that may not be familiar with GoToWebinar, there's a panel on the right side of your screen, and this is where you'll be able to ask your questions. It's a questions pane, or it's a chat box. And basically, you can type your question in there, and you can do it all through the presentation. And At the end of the webinar, I'll be facilitating that Q&A session, and I'll be able to get to as many as I possibly can, and to the extent that we're able to get some answered afterward, we certainly will try. But anything along the way, it will save it, and at the end, I'll be able to see all of them. So please use that question box to enter your questions. Our technical facilitator today is NADAC, and Misty Story is behind the scenes, and she's the Director of Training and Professional Development and an expert in conducting webinars. And so if you're having technical issues, you can certainly you can put that in the chat box, and Misty will be able to try to help you in any way that she can. She'll also be able to make available some of the links we'll be referencing along the way, so you'll see that she's posting links about in fact, she's already posted a link to the Hospital SBIRT site where the nursing CEs are offered. So if you look in your pane, this is where she'll be communicating with you around technical issues and some of the links. We have two presenters for you today. We have Deborah Fennell, who is at Johns Hopkins University School of Nursing. And Deb has been registered nurse for over 4 decades, specializing in psychiatric and mental health nursing, prevention, and treatment of substance use disorders. She has published on the role of the professional nurse in SBIRT provision, integrating content on the continuum of substance use into nursing curricula, development, and testing of SBIRT implementation models, all with the goal of moving SBIRT into the mainstream of nursing practice. Her current work focuses on integrating SBIRT-related content in the Master's Nursing Curriculum at Johns Hopkins University. She recently produced and is currently testing a brief video intervention designed to bring the evidence about the neurobiological base of alcohol use disorders directly to at-risk individuals. And our other presenter today is Lauren Broyles from the VA Pittsburgh Healthcare System and University of Pittsburgh. Dr. Broyles is a doctorally prepared nurse with advanced postdoctoral training in health services research. She is currently a health services researcher at the VA Career Development Awardee with a program of research focused on improving the identification and management of alcohol misuse among hospitalized veterans. Specifically, her research is evaluating the efficacy and implementation of nurse-delivered alcohol screening, brief intervention, and referral to treatment in inpatient and primary care settings. Dr. Broyles is also the co-director of the Pittsburgh site for the VA's Office of Academic Affiliations Advanced Interprofessional Fellowship in Addictions Treatment, and an assistant professor at the University of Pittsburgh School of Medicine, and an assistant professor of Clinical and Translational Science at the University of Pittsburgh, and assistant professor at the School of Nursing. Additionally, she currently serves as the secretary for Interdisciplinary Organization, AMERSA, the Association for Medical Education and Research in Substance Abuse, and as associate editor for the peer-reviewed journal Substance Abuse. Her clinical background is in the Substance Abuse Consultation Liaison Services at the University of Maryland Medical Center. So please join me today in welcoming both Dr. Deb Fennell and Dr. Lauren Broyles.
Thank you, Tracy. That's a really great introduction, and we're really happy to be here today. I know I can speak on behalf of Deb as well. This is something that we are really passionate about, the whole idea of nurses being able to incorporate techniques and an approach into their practice that really will allow them to respond to this whole spectrum of substance abuse, all the way through from youth to substance use disorders. And we'll say a little bit more about that as we go along today. We have 4 main objectives today. The first is to really explain how and why screening, brief intervention, and referral to treatment, which I'll refer to by the acronym SBIRT, is an appropriate skill set for nurses across all healthcare settings, really being able to, again, respond to wherever the person is in their use. We also want to help people understand how to differentiate screening, assessment, and brief intervention, because they go together as a package, but they're very different and separate. The third goal is for us to give you some practical stylistic strategies for how you can incorporate SBIRT activities into your practice in a way that feels natural and comfortable. And then our fourth objective is to have you guys analyze a simulated patient brief intervention that Deb and I will conduct so that you can pick out what some of the key components are and see how we actually operationalize all of those in real life. Again, with the purpose of you being able to apply it to your own practice, whether you're a nurse or you're an addictions counselor or a social worker. I know we have a mixed audience today. Really briefly, right off the bat, we want to get on the same page with some general terminology and concepts so that we're all talking about the same thing. In general, the DSM-5, which is the Diagnostic and Statistical Manual for Mental Disorders, just came out, and there have been some changes. We're actually going to be talking about the whole range of substance use, all the way from use to risky use, and then the most substantial or severe use as being substance use disorders. There have been some changes in the DSM where essentially they have removed the categories of abuse and dependence and have reclassified substance use disorders into 3 different subclassifications, which you see in the second set of bullets there. They still have the criteria that you need to meet in order to be diagnosed with a substance use disorder, but depending on how many of those 11 criteria that you meet determines the severity of the substance use disorder. This is to really clear up some confusion about abuse being able to stand independently as a condition or a diagnosis and not necessarily as a precursor to dependence. They also made some other changes in those criteria. They removed the legal problems criteria and added one instead related to craving or a strong desire or use, desire or urge to use the substance. What I really want to stress that we're focusing on today in the webinar is this notion of hazardous and harmful alcohol use. And this is a new concept for a lot of healthcare providers, particularly those who have been in the specialty treatment setting. Hazardous alcohol use or harmful use is not the same as an alcohol use disorder. These patterns of alcohol use are recognized by the World Health Organization, but it's important to realize that these are really referring to patterns of drinking that either carry an elevated risk for someone to have increased physiological or psychosocial or interpersonal problems, or use that is a pattern of drinking that's causing harm to someone's health, but may not meet criteria for alcohol use disorders. So what I really want to stress is that we're screening people and responding to people who may have these quote-unquote lesser forms of alcohol use. The whole purpose of SBIRT is to take a preventive orientation towards substance use and respond in an appropriate manner based on whatever the person's current use pattern is. We're not going to wait to respond to alcohol use until they are all the way at an alcohol use disorder. We're going to respond earlier. So the drinker's pyramid here really helps illustrate this. In general, we tend to think both as a healthcare population, as a lay population as well as healthcare providers, tend to think of alcohol use in this 2-bucket model, being the yellow, the abstainers, or the green, the tip of the pyramid, where you have an alcohol use disorder. We tend to think that you're an abstainer or an alcoholic, but the reality is that many Americans use at levels that correspond to the purple or the peach. And the notion there is that people's drinking can progress across a continuum, and we can intervene earlier before things become a problem. Traditionally, what we do is wait until someone reaches the tip of that pyramid when they have an alcohol use disorder before we say, oh, someone ought to talk to this person about their alcohol use. At that point, they're on the renal transplant list, or they're in the ER with their 3rd DUI, or they're attempting to enter a treatment program. The idea is that we can respond much earlier. Now, the dividing line between the purple and the peach, the dividing line between what constitutes a hazardous drinker versus a low-risk drinker, is based on the guidelines issued by the National Institute on Alcohol Abuse and Alcoholism. VA and the Department of Defense have also adopted those guidelines. And I'm going to say a little bit more about those in general, or in just a moment, but in general, exceeding those guidelines places you into the hazardous drinker category. So, before we introduce what those guidelines are, we need to backtrack and talk a little bit about what constitutes a standard drink. This is really important because when you're doing an assessment of how much your patient drinks, you really need to understand that not all alcohol is the same. So a standard drink is defined as basically a shot, a 5-ounce glass of wine, or a 12-ounce can of beer. So that becomes really important because in local channels, I know when I was in Baltimore, for example, you'd have patients say that they drink double deuces, or they drink a 40, or they're drinking Long Island iced teas. Each of those alcoholic beverages is actually anywhere from 2 to 3.5 standard drinks because a Long Island iced tea, for example, contains multiple shots of alcohol. A double deuce is a 22-ounce beer, and a 40 is a 40-ounce malt liquor beverage. So it's really important to be able to have these 3 guidelines in your head for what constitutes a standard drink so that you can accurately record and assess how much your patients are drinking. So back to those hazardous drinking criteria, now that we understand what constitutes a standard drink. The guidelines recommend that healthy men under age 65 consume no more than 4 drinks per day and no more than 14 spread out over the week. For women, healthy women and healthy adults over 65, the guidelines are no more than 3 drinks a day and no more than 7 drinks per week. And so again, these guidelines, exceeding these guidelines does not mean that that the patient has an alcohol use disorder. What it means is that they are at higher risk for having any number of alcohol-related health conditions, risk of illness and injury, psychosocial problems, etc. What I've found helpful in terms of conveying this information to clinicians as well as patients is to really think about these numbers in the same way that we think about blood pressure targets. We have blood pressure targets of 120/80 for healthy adults. And when people's blood pressure has exceeded those target numbers, if say it's up at 145/90, we don't panic, but we do talk with that person about some lifestyle changes that they can make to reduce their risks of cardiovascular disease, heart attack, or stroke. And the goal is for them to bring their blood pressure down to the target number. It's helpful for us to think about these in the same way, that the goal is not necessarily for this person to stop drinking altogether. The goal is for them to reduce, say, from 10 drinks a week, which is pretty easy to do if you think about it. If you're a 40-year-old woman who comes home and has a glass of wine each day after work and then another with dinner, that woman is technically a hazardous drinker. She's consuming 10 drinks a week. The goal is not for her to abstain. The goal is for her to reduce down to the guidelines. What's important to note here is the set of bullets at the bottom. The first set of bullets in those guidelines really pertain to healthy adults. When someone has a health condition that could be exacerbated by alcohol, is taking medication that could potentially interact with alcohol, or is pregnant, then the guidelines really are recommended as abstinence or even lower limits. What I would encourage people to think about in terms of health conditions exacerbated by alcohol, immediately the first things that tend to come to mind are pancreatitis, liver disease, etc. But I would really encourage people to think a little bit more broadly and widen that lens. Even conditions like diabetes or hypertension, many conditions can be exacerbated if you think about in terms of excess alcohol on board, making glucose management trickier, and then delaying wound healing, for example, in a diabetic patient. So just as an example, it's really important to stop and think and do the math when you're assessing someone. So a 52-year-old man who's having 3 12-ounce beers each day is not within the recommended guidelines. So remember, for men, the recommended guidelines are no more than 14 a week or 4 at a time. He's below the daily limit, but when you do 3 times 7, he's actually having 21 beers a week. So he's exceeding the total recommended amount for the week. Whereas someone in the second bullet who may have a more sporadic pattern of alcohol use is actually within the guidelines. So here, a 52-year-old man who has 3 beers on Sunday, 2 on Wednesday, 4 on Thursday night, and 3 on Friday night is actually within the guidelines. These are based on both quantity at a single occasion as well as overall quantity over the week. And so he's having no more than 4 a day and no more than 12 over the course of the week. What I'd like to shift into now is really getting into some of the nuts and bolts about how and why nurses across all healthcare settings, regardless of what your position is, your nursing practice level, or your patient population, why it's important for nurses in particular to be able to identify and manage substance use. So there are a lot of reasons why nurses make sense. First of all, nurses are the largest group of healthcare providers in this country, and 60% of all nurses in the U.S. work in inpatient care settings. We are the professional group with the largest amount of extended patient contact. So whether you're talking about an outpatient setting or inpatient, 12-hour shift, 8-hour shift, even though we're all busy and have less time with patients than we'd like, nurses tend to have the most face-to-face contact. In a lot of settings, too, we tend to be the most regular and stable providers. So again, I'm thinking mostly of inpatient settings where the residents and other healthcare providers may change month to month, but nurses in both outpatient and inpatient settings really remain a stable workforce. We also have existing skill sets in patient education and also in patient-provider communication that really lend themselves well to some of the SBIRT skills that we're going to be talking about. And we have a practice style that is highly congruent with SBIRT. Nursing practice style tends to be a little bit more, I'm painting with a broad brush, but it tends to be a more negotiated style as opposed to a more directive or authoritarian style, which is the style in which physicians are traditionally trained. And nurses consistently rate as the most highly trusted profession in the annual Gallup polls. And that extra trust and comfort that people feel with nurses may help make potentially sensitive or stigmatizing conversations like those about alcohol or personal health habits a little bit more comfortable. And finally, there's been a much more of a push for interdisciplinary involvement in terms of addressing alcohol use. The goal being that having multiple healthcare providers across the scene address alcohol with patients not only increases the salience of the message, but also helps spread out some of the burden associated with addressing things in very tight clinical environments. So I've also had the question in the past of how exactly SBIRT fits in with nursing practice and how exactly it can help people on a daily basis care more comprehensively for their patients. One of the first reasons that I give always is that alcohol use and use disorders are really common. I used to hear when I was working in Baltimore on 11 East, people say, oh, I don't know how you work with those patients, those substance-using patients. I'll just stick with my plain old diabetics or my elderly patients in the nursing home. With very few exceptions, all of those patients are we see substance use in all of those populations. It's just that we're not asking. Alcohol use is linked to a whole slew of acute and chronic conditions. And so it's really important for us to understand if we're going to respond and manage our patients' health conditions well. Particularly in inpatient settings, universal screening allows nurses to have early detection of potential acute withdrawal risk. Countless times nurses are surprised in the inpatient care setting because alcohol screening is not, comprehensive and systematic alcohol screening is not part of the intake admission assessment. And so 2 to 3 days into hospitalization, nurses and physicians are caught off guard when alcohol withdrawal symptoms start to appear, and it can be very difficult to manage at those later dates. We also always want to be screening and assessing our patients so that we can make appropriate referrals for additional resources, whatever our patients may need in terms of additional education, case management, or referrals to treatment. In the admission or intake assessment, we also have what's commonly referred to as this teachable moment, where we can draw some links between patients' current health condition or the presenting problem and relate that to their substance use and really help patients understand the role that some of their lifestyle changes collectively over time, the ways that those impact their health. Additionally, I'm going to say a little bit more about this in a few moments, but SBIRT also allows us to have an upstream preventive orientation towards substance use. It is based on a health promotion model, again, that responds to whatever the person's level of alcohol use is, instead of waiting until they reach that tippy-top green part of the pyramid when substance use is often most devastating, most complicated, most difficult to treat, and most costly to treat. This whole orientation is shifting things backwards towards more of a, I don't mean backwards in a pejorative way, but backwards to earlier in the use patterns, more of a public health approach. And finally, although there isn't a lot of research out there specific to either nurse-delivered SBIRT or really a lot of literature outside of the trauma setting, there is some evidence suggested that for every dollar spent on SBIRT, $4 can be saved in healthcare costs down the road. We're not sure about the impact of addressing substance use in this way on patients' lengths of stay in the hospital or readmission or even their service utilization, but all of those are particularly salient questions that are starting to emerge right now as different healthcare systems and third-party payers look at reimbursement for SBIRT services. Okay, I'm going to move into now our second objective and actually talk a little bit about what each of these pieces are. As I mentioned a few moments ago, the goal of SBIRT is to decrease the burden of alcohol-related injury, disease, and disability. It does have this preventive public health orientation. And there are three components to SBIRT. The S is screening and assessment, the BI is brief intervention, and the RT is referral to treatment. The purpose of screening is to assess the extent of someone's substance use and then identify the appropriate level of treatment or response that's needed. You can think of it as casting a broad, wide net first that's looking for a signal on the radar. The tools for doing screening, we really are going to get into talking about how it's important to use a standardized screening questionnaire that is appropriate for the patient population that you're working with. The second component of SBIRT, the BI, is brief intervention. And the purpose of brief intervention is to increase the patient's awareness and own insight about their substance use, and then tap into their head and their heart to get a sense of what's motivating them potentially for changing behavior. Some of the things that we think should motivate someone may not be what actually motivates them, and it's important for us to understand from the patient's perspective. Brief intervention, we're going to go over a style or form of that today called the brief negotiated interview, which is usually about a 5 to 10 minute conversation that does contain certain elements and certain stylistic strategies that we're going to teach you how to use. For patients whose substance use is more substantial, they need a higher level of assessment and care. And so referral to treatment is the RT in the SBIRT acronym. And it provides those people who need more comprehensive evaluation or treatment with access to specialty care. And it's important in that case that we have very clear and efficient referral processes as well as some patient education resources when people aren't ready. So if we come back to this pyramid for a second, I want to talk and just illustrate how, again, SBIRT allows us to respond to the entire continuum of substance use, wherever the person is. And so the S, the screening, as you can see, encompasses the entire pyramid. The idea here is that it's universal screening for every patient, every time, not case finding or cherry picking or sort of guessing as to who we think might have an alcohol use condition. It's universal for everyone. For patients who are drinking below that waterline, patients who are low-risk drinkers or abstainers, the response, the appropriate clinical response, is positive feedback and encouragement and a prevention message of, hey, great job. You're actually within the recommended guidelines. This is going to be really important for your diabetes management. For patients who are hazardous drinkers, the appropriate response is brief intervention. So again, the goal here is to encourage and help motivate that person to make a reduction in their drinking, back down to those recommended guidelines that I mentioned. For patients whose alcohol use is more substantive, people who are at the top part of that pyramid in the green, those are the patients that need referral to treatment. Right now, we are typically only responding to patients who are in the upper cap of that pyramid. And again, the irony there is that that is when alcohol use is most complicated, most severe, most devastating, and most clinically difficult to treat, as well as being most costly. So SBIRT allows us to respond to patients earlier at every stage of this pyramid. So again, the purpose of screening, we're going to go over that. I'm going to go over some screening instruments that can be used, and we're going to introduce some of the screening tools that are available, and then what you actually do with a positive screen. There's so many times that we screen for things, tick off boxes, and then nothing happens. But the goal here is for screening to really drive the care plan. As I mentioned earlier, screening is a universal first pass. It's casting a wide net. And the most important thing is to use a tool that is specifically validated for your population. I'm not going to go through each of these screening instruments, but just wanted to give you a flavor of the different ones that are out there. And you can see, I really want to draw your attention to the last two columns on the right, where we're indicating what the instrument actually screens for and who the target population is. It's really important that you have a match here. Many people, for example, I know at least in nursing school or medical school, we're taught the CAGE. But the CAGE is an instrument, that's where it's asking, how often have you attempted to cut down? Have other people been annoyed by your drinking? Have you ever felt guilty about your drinking? And do you need an eye opener in the morning? The point is that I want to make about the CAGE, though, is that the CAGE is only screening for people in that upper green tip of the pyramid. So if that's what you're looking for, folks who are dependent, you will find them with the CAGE. You will not find those individuals though, who are hazardous drinkers. And so it's really important that you're using a tool that is going to detect what you're actually looking for, and that it has been psychometrically validated to be accurate and appropriate for your particular clinical population, whether it's adolescents or adults or older adults. We're going to introduce the AUDIT-C today. The AUDIT-C is what the VA uses, and it stands for the Alcohol Use Disorders Identification Test Consumption. This screening instrument is actually the 3-item short version of the full audit, which is a 10-item instrument developed by the World Health Organization and validated in, I think, 13 different languages. Essentially, these questions assess the quantity of drinking, frequency of drinking, and frequency of binge drinking over the past year. There are different cut points for men and women, and also for age. For women, scores of 3 and above are considered positive. Men, it's 4 and above. And scores of 8 or above are suggestive of alcohol dependence. So again, I just want to reiterate that scores of 3 or 4 for men or women are going to identify people in that purple zone of the pyramid, the hazardous drinkers. And scores of 8 or above are going to be suggestive, but not diagnostic, for folks in the green upper cap. We have a sample of the item that we'd like to, the instrument that we'd like to show you. Essentially, patients are given point values for each of these 3 questions. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you are drinking? And then how often do you have 6 or more drinks on one occasion? Very simply, you sum the point values for all 3, and that gives you your score, which you then reference against those gender and age-based cut points. So for patients who are positive on the AUDIT-C, who pass, as I said before, that first blip of detecting a signal that there may be an issue here, we want to go into assessing whether or not they are also exceeding the recommended guidelines that I mentioned earlier. This is very simple to do, but it does require that you really get a solid number from patients, as opposed to on the audit where it was many of the response options had a range of choices. It's really important here to get a sense of how many days during the week the patient does drink and how many drinks they have when they do drink. So, oh, I drink Thursday, Friday, and Saturday nights, and I usually have probably 4 beers per night. 3 times 4 is 12. Right there, that would also start to suggest, and then in that case, I would meet the second criteria as well for binge drinking for women. So I would be having then more than 3 drinks per occasion. So essentially, I would be meeting the hazardous drinking criteria because I'd be exceeding the weekly number for women my age, and I'd be exceeding the per occasion amount for women my age. I'm going to back up for 1 second. Whoops. When people exceed the recommended guidelines and are considered hazardous drinkers, these are the folks that are appropriate for brief intervention. Obviously, someone who has more of a substantial alcohol use needs more than a 5 to 15-minute conversation about reduction. So we really want to check and make sure whether or not someone has an alcohol use disorder, if they are in that tippy top of the green section of the pyramid. There are a couple goals for doing this. We want to determine someone's risk for alcohol withdrawal, which is one of the few withdrawal syndromes that you can actually die from or experience serious complications from. And we really also want to determine the potential need for referring someone on for more comprehensive care. In the clinical arena, in the absence of having a psychiatrist or substance use specialist available to do a comprehensive intake, some of the tools that people can use to be reflective of the possibility that someone does have an alcohol use disorder is, again, to use the AUDIT-C score of 8 or above, or also the CAGE, which again is specifically trying to capture that upper part of the pyramid. 2 or more responses, 2 or more affirmative responses on the CAGE are also highly suggestive for alcohol use disorders. And those are the people that are appropriate for referral to treatment. One of the other things that Deb and I really want to make an important point is that although there aren't validated clinical tools right now for assessing whether or not someone is in recovery, clinically speaking, it can really be an important set of questions. It's important for us to recognize that people's alcohol consumption or other health behaviors are not static. They change over time based on people's just changes in the lifespan or in personal circumstances. And so what someone's alcohol use was last year may not be the same as what it is today, and vice versa. It is really important to ask whether or not people are in recovery. One of the easiest ways to do that is to simply ask, would you consider yourself to be a person in recovery? Are there times when your alcohol or substance use was different than it is now, more specifically when heavier than it is now? And it's really important to keep our ears open for those key psychosocial changes that happen in people's lives that may trigger changes in their substance use. So for example, the death of a spouse or a child, the loss of a job, any of those big life transitions may signal increased risk for changes in someone's substance use pattern.
Thanks, Lauren. So now I want to echo your comments earlier about how pleased we are to be presenting this webinar. I'm going to shift the thinking a little bit to move to some of the drug questions. So far, Lauren's focused on alcohol use, and we're going to talk a little bit about some screening for drug use. So there's a simple drug screening question that can be easily used in clinical practice, and this is especially important for people who may be experiencing a medical testing or surgical procedure, or where they've experienced some kind of trauma and we're considering pain treatment, for example. And this is how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons. And this has a really high sensitivity and a fair sensitivity in terms of being able to detect people with drug use. The drug abuse screening test is an additional test, a little bit more extensive. And this yields a quantitative index of problems that are related to drug misuse. The strengths here are that it's very sensitive for screening for at-risk drug use. The weakness is that it doesn't include alcohol use, and the focus is on dependence. It also doesn't distinguish between active and inactive use. So the questions that Lauren just mentioned with respect to recovery are really important to include in your assessment of patients. And the tool does not include quantity, frequency, pattern, duration, or the type of drug used. So the nursing assessment would want to go further to assess those characteristics. This shows the 10 items for the drug abuse screening test, and as you can see, the responses are simply a yes or no dichotomous response, ranging from have they ever used drugs other than those required for medical reasons, to some of the consequences that may have been experienced as a result of drug use. So you see some of the guilt, the blackouts and flashbacks, aspects related to impacting family, legal consequences, and then also medical consequences. So the DAST can be interpreted fairly easily, shown here on the left column, the scores. Again, the way that this is scored is to total up the number of yes responses. So a score of 0 means that there's no problems reported and no action is needed at the present time. A score of 1 to 2 would indicate a low level of risk, and the importance of monitoring and reassessing at a later date is indicated. A moderate level, 3 to 5, would require further investigation. So again, looking at some of those questions related to quantity, frequency, pattern, duration, or the type of drug that's used. And then finally, the highest level, 6 to 8, the substantial level, or higher than 8, would be where intensive assessment would be indicated. We're going to move now to the third objective, to begin to look at some of the stylistic strategies for incorporating SBIRT into routine nursing practice. We'll talk a little bit about some of the common assumptions about health behavior change and the trans-theoretical model that's integrated throughout the brief negotiated interview that we'll demonstrate later. So some of the common assumptions about behavior change may be assumptions that you've held or you've heard from other people, where there is a belief that the person ought to change, and that just recognizing or seeing kind of the consequences that the person is experiencing is enough to make them motivated to change. There's also an assumption that the person's ready to change. And oftentimes we approach people with that assumption without really fully understanding what their position is in terms of their understanding of their alcohol or drug use. The person's health is a prime motivating factor for him or her. So we'll talk later about this and see how it's important to help the patient or the person associate those medical consequences with the alcohol use. So as Lauren talked about earlier, making that connection between alcohol use and hypertension or alcohol use and diabetes is really important. And people may not understand that there's a relationship between alcohol, drug use, and their health.
And Deb, if I
and also, sure.
Sorry. If I can just interject too, you know, the reverse can be true as well, and we need to be open to that as well. That for us, it may seem rational and natural that someone who just had a cardiac-induced, a cocaine-induced MI may be interested in stopping cocaine use because of his or her health. And we think that this is clearly a prime moment for that. But the person may not be interested in necessarily stopping because of his or her health. That may not be what's motivating him or her. It may instead be all of the money that he is spending on the cocaine use, or the relationship with his girlfriend that is being damaged. And so one of the things that this particular technique that we're going to show you allows you to tap into is it the health side that's important to someone, or is it maybe one of these other things? Because as healthcare providers, we want to stress the health side, but very often that may not be what matters most to the patient. So both sides can be true.
That's a great point, Lauren. And I think again, our perspective as healthcare providers is we see the logic in this in terms of the connection between health and substance use, but that may not be the same kind of logic or sequence that the person who's experiencing that holds for themselves. And the other component is that if a person does not decide to change his or her behavior, then the consultation has failed. And I think often we're in the professions that we're in, we're here because we really want to help people. And when our efforts or our initiatives don't seem to be successful, we take that on as our own failure, and that we then in turn may project that onto the patient and blame them of, I could really be an effective nurse if that person would change their behavior. So these assumptions are really important to consider as we move forward with how to provide this set of clinical strategies in our day-to-day practice. Another assumption is that patients are either motivated to change or not. So we view this as a dichotomy. And if the person's not motivated, then our temptation is to say, well, I'll come back when they're ready to change. And that will show you the strategies that we can help to move that motivation along the trajectory. Now is the right time to consider change. So as Lauren just presented, the person who comes in with a cardiac-induced problem because of cocaine, as healthcare providers, we would think, oh, this is the great time to really approach them with this connection between their health problem and their drug use. We may believe that that's the right time for them to consider change because of that specific reason. But in fact, there may be other motivating reasons for the individual to consider change, or that they may decide that they're not ready to consider change. A tough approach is always the best. Another common assumption. The finger pointing, the lecturing, I know what's best, hands on the hip approach is not one that is effective. That's an approach that's clearly not patient-centered. And as nurses and other healthcare providers, we want to come to that relationship with our patients in a way that is engaging them to really motivate them and move them toward change. And then finally, the assumption of that we're the experts and the patients have to follow our advice. We may be tempted to give advice, and there may be times when that's appropriate, and we'll demonstrate that later on as well. But it's important for us to really try to understand the experience of the patient and to put the whole conversation in context with them so that we don't come across as being expert or arrogant. So one of the constructs of the trans-theoretical model shown here are the stages of change. And what this graphic, though it looks rather busy, but what this graphic shows is that people progress through stages of change, and it's not in a linear fashion. So primary stages of change, pre-contemplation, contemplation, preparation, action, and maintenance are shown here. Pre-contemplation means that people may not be aware that they have a problem or that they're under-aware that they have a problem. In contemplation, people are beginning to think that they may have a problem, and they might even begin to start to think about doing something about that problem, but they're not quite ready yet. As people move into preparation, they're thinking that they may be willing to make a change, maybe not right at the immediate time, but in the near future. In the action stage is where we begin to see those behavior changes actualized. In this stage indicates that somebody may have tried to cut down their alcohol use, may have had a period of time where they've been abstinent, and it's reflective of tasks where they're struggling to maintain that behavior change. So action, in people who are in action, really are putting out a lot of effort to try to engage in that healthy behavior or reduce that unhealthy behavior. And then finally, in maintenance, is where individuals are adopting that behavior change, making changes in lifestyle, developing new coping strategies that are helping them to maintain abstinence from alcohol or other drugs in this example. And I think what's helpful is to think about this in terms of behavior changes that you've gone through, where you may have said, I know I need to lose a little bit of weight, or I know I need to get a little bit more exercise. And if you think back at those experiences and how these stages of change, how you may have progressed through these stages of change and gone back and forth between pre-contemplation and contemplation, or contemplation and preparation, you begin to understand and relate to patients who are similarly challenged as they go through the behavior change of reducing substance use. Importantly is the concept of relapse, that along the way situations change, context changes, and that relapse can occur at any point along the continuum. As we encourage patients to set realistic goals, and as they may have a slip from that goal, it's important to acknowledge that the relapse is a normal part of the process, or can be a normal part of the process. And so to not criticize people for relapsing, but helping people to get back on track and working back toward their goals.
Deb, may I make one or two more points about that?
Sure.
Thanks. I wanted to talk, you really did a nice job of focusing on how this stages of change model really helps us meet the person where they're at, so to speak, and really respond to whatever stage of the change process we're in. And I just wanted to point out how so many of our systems really assume that patients are either at pre-contemplation or action. So for example, in the VA, the inpatient nursing assessment asks, do you smoke cigarettes or use nicotine products? Yes or no. Are you interested in quitting? Yes or no. And it's this dichotomous answer where we either assume people are pre-contemplative, they're not interested, it's not on their radar, which would be the no, or yes, I'm ready to take action today. And yet the reality is that people are often in these contemplative or preparation stages, and we can't assume that all of our patients are at action. Again, it goes back to those assumptions that you covered. It can be just as meaningful of an intervention, a nursing intervention or a counseling intervention, to help somebody move from pre-contemplation to contemplation. It's not a failure if you aren't working with someone in the action stage. This is all an important part of the process. While this model can help you think about how to deliver patient-centered care, I think it's also really important for helping prevent staff burnout. Because if we're all as healthcare providers assuming that everybody is at that action stage, and we're having what we think is an ineffective encounter with someone at that action stage, we're going to increasingly feel worn down, bitter, cynical, etc., feeling that we're not effective and feeling like we are just a cog in the wheel regardless of whatever someone's substance use is. But when we realize that we can be effective earlier on, at earlier stages, when someone is still chewing on this mentally or working through it, then we relieve the potential for some of that burnout for ourselves as well.
Right. I think good comments, and I think that, again, what's nice about this this construct of the model is that it does go back to help refute some of those assumptions that we went over earlier. So in brief intervention, we're going to talk about what it is and what it's not. And that, as Lauren talked about earlier, brief intervention is targeting patients that are in that upper part of the pyramid, the people who are identified with hazardous use and also those with a disorder. So for hazardous use, we're using brief interventions to really encourage them to move along that trajectory of change and to adopt healthy behavior. And for those at the top of the pyramid, those with a disorder, we can use these brief interventions to encourage people to accept a referral to treatment. We're going to go over the brief negotiated interview, do a couple of C&I role plays, and then we're inviting you to critique as we go through these role plays. So the brief intervention is a short 5 to 15-minute dialogue that involves feedback and engagement, simple advice or brief counseling. So there's that advice word that I mentioned earlier. So we'll give some examples of how to provide some simple advice. It also involves goal setting and follow-up. And as we've talked with the stages of change, this is based on the trans-theoretical model and motivational interviewing. Brief intervention is geared toward hazardous drinkers, and again, for those with an alcohol use disorder or a substance disorder at the top of the pyramid, we can really utilize these same skills to encourage people to accept a specialty treatment. So Lauren's going to be going through this in greater detail after our role play, but quickly the steps of the brief negotiated interview are to raise the subject, which is an essential component, is to establish rapport and seek permission, to provide feedback, which is reviewing the screen, reviewing where they are in terms of the risk category, and the guidelines for risky drinking. And the third step is to enhance motivation, where we explore the pros and the cons, the good things and the not so good things about what they're experiencing. Assessing readiness to change, again, as we talked about earlier, the stages of change, where are they in terms of that stage of change? Are they pre-contemplation, contemplation, preparation, action, or where along that trajectory of change? And in enhancing motivation, it's to really encourage and to identify discrepancies. So where's the rub for that person of their substance use in any of their health or other consequences that they might be experiencing, and to really bring that to light and show them the discrepancy. And then in the fourth step, to negotiate and advise. Here we look at exploring options, negotiating a plan, and encourage them to consider follow-up. So we're going to move now to a role play, and I'm going to play the role of John Sawyer, and Lauren's going to play the role of the nurse. To put this into context, John Sawyer is a 60-year-old male who consumes 4 to 5 standard drinks on a regular basis. He's admitted to the hospital for chronic renal disease, and he has some neuropathy or numbness in his lower extremities, particularly his feet. And this is likely attributable to poor diabetes management. So Lauren is completing the nursing assessment form. The hospital has recently changed the admission form to include information about alcohol, tobacco, and other drug use. And the nurse is not comfortable with the change and has had limited instruction on how to obtain this additional information from the patient. So let us introduce you to Mr. Sawyer and Nurse Nowak.
Okay, so Mr. Sawyer, I have a few more questions to ask you. We just started using this new assessment form, so I'm kind of just getting used to it. And let me see. They want us to ask you about your drinking. Sorry, I have to do that. So, do you drink alcohol?
Well, yeah. Do you?
Oh, wait, that's not the way I'm supposed to ask that question. Let me try again. When you drink alcohol, how much do you drink?
Well, just a few beers after work.
Okay, well, I have to put a number in this box, so what would you say? Like, how many is a few?
I don't know. I guess maybe 4.
Okay, that'll work. I'll put in 4. Oh, wait, I have to know. Wait, back up for a second. Is that for a day or for a week? I'm guessing that's a week, right?
Well, these questions seem pretty stupid. I'm not sure what this has to do with why I'm here in the hospital.
I know, I understand. It's just that I have to ask all these questions to all of my patients. We see a lot of patients here who end up winding up going into DTs, and you know, because you're pretty sick, it might be because you've been drinking. They just want to cover all the bases. I'm sorry.
Really? What does drinking have to do with my medical problems? I don't think I like where you're going with this.
Look, I'm really sorry, but I need to know how much you drink in a week. Can you give me a number just so I can fill this in?
All right, sure, okay. Just put in 4 a day over the week. Can you do that math?
You know, sir, there really isn't a reason to be sarcastic. I'm just trying to do my job, and maybe, listen, I'll come back later when maybe you'll feel better and you'll be in a better mood. How about if I finish this up after you have your lunch?
Oh, good. I can't wait. So now, Lauren, let me turn it back over to you to go through the good steps of a brief negotiated interview.
And so our goal is to show how important screening is in really setting an appropriate stage and establishing some rapport with patients. Although that scenario was, you know, obviously we constructed that, it's definitely based on things that we've seen or witnessed in terms of both the clinician's discomfort as well as the patient's discomfort, which ends up being contagious in both ways. So our goal is to really introduce some new ways of being able to talk about alcohol use as well as do the pieces that we all need to do for our jobs in terms of documenting things appropriately. We're going to go through what's referred to as the brief negotiated interview. This is a style of brief intervention that was developed by Dr. Gail D'Onofrio, who is an emergency room physician. So it's meant to be highly practical, highly usable in fast-paced environments where clinical time is of the essence and where patient acuity may be an issue. We're going to go through each of the steps that Deb mentioned a few moments ago. The first step is really raising the subject in such a way that establishes rapport, asks the patient for permission, and sets the stage for the conversation. Helps people feel like they're not going to be caught off guard. I found a really helpful way to do this when I was a staff nurse was presenting the need for this information in the context of health risks. My personal feeling is that although the attempt to normalize things by by saying, oh, this is something I have to ask of all my patients, or this is a form I have to fill out, doesn't necessarily create a safe psychological space for people to be candid. It really inadvertently, in my mind, can send a message of, I just need to do this quickly, let's just go through the boilerplate stock answers and questions, as opposed to really being able to connect with people. So I prefer to present it this way, saying something like, we often go over different health risks with our patients, where we need to get an assessment of what your body's used to in terms of alcohol and tobacco and other medication or drug use. Is it okay if we spend a few minutes first talking about your use of alcohol? And that way it sets the stage for me as a clinical professional, not as a cog in the healthcare wheel who's just ticking boxes and filling out forms, but it gives some credibility, clinical credibility, as to why I'm asking these questions.
So, Lauren, can I just jump in here?
Sure.
And I think that point's really important, is that when nurses think about doing this, one of the things that we've done for a long time is we've obtained a medication history, and we ask patients, what medications are you on? And that's a normal, natural part of our nursing assessment. And I think by asking those kinds of questions within that context is a great way for nurses to easily move from a practice that they've done for a long time into this maybe new territory for them of asking about substance use.
Yeah, that's a great idea. That's something that is very common across settings for nursing practice, and a nice way that you can segue into some of those more or less familiar or slightly more sensitive questions. Step 2 in the brief negotiated interview is actually providing feedback. We all know as nurses or as other healthcare providers the millions of times that we're being asked to screen for things that we never do anything with the information with. It sits in the folder or it sits in cyberspace and doesn't actually get reincorporated into the next step. What brief intervention does is takes those screening results that we used with the Audit-C and back where we screened people and got the number of drinks per week, and we're going to review those with the patient and compare and contrast their responses with what those NIAAA guidelines are. What this in essence allows us to do is use an objective standard like the NIAAA guidelines to let the patient know that their drinking pattern is exceeding what is recommended. So it becomes this comparison to an objective standard as opposed to a subjective judgment of, well, I think you might be drinking too much, blah, blah, blah. Here we're just mirroring that back to the patient and using those screening results to jumpstart the conversation. The next step is to really personalize that person's risk. It's much more important to, when you see a health connection, and again, I encourage you to think broadly, to personalize that for the patient as opposed to just saying, well, we know you're at higher risk for illness and injury. But it's important to personalize that risk after you ask the patient first what connection he or she sees between their drinking and their health condition or reason for admission. So what connections do you see between your diabetes and your use of alcohol? Or what connections do you see between your lack of wound healing or your CHF exacerbation and your drinking? And give them a moment to think about it and draw any of the comparisons. And it will help you also identify what their teaching needs might be in terms of the health risks. The third step in brief negotiated interview is commonly considered the meat of the encounter. And we're doing two things in this stage. We're assessing somebody's readiness to change, figuring out where they are in that stage of change process, because it's going to drive how we respond to them. And then we're also going to develop some of that cognitive rub, or that discrepancy. A couple ways that we do this. Nurses are very familiar with pain scales and other numeric scales where patients are asked to rate things. It's really important that we get a sense of how ready someone is to make a change in their drinking, with 0 or 1 being not ready at all and 10 being very ready. And the idea here is to give people permission to respond anywhere along that continuum. Most patients aren't a 0 or a 10. They're somewhere in between. And so we can use that readiness ruler and those mental anchors, get a response from someone, and then elicit a little bit more information by saying, okay, so you're a 6 in terms of your readiness to make a change. What made you say a 6 and not a 2? And that helps the patient articulate all of their reasons for making a change. well, I'm a 6 because I'm starting to realize that I'm starting to gain weight, and my wife is nagging me. The flip side of that is you can also ask someone, so you're a 6. What do you think it would take for you to move to a 7 in terms of readiness? Well, if I found a way to deal with the peer pressure at the bar, then I might be a little bit more willing to make a change. One of the second strategies for developing discrepancy is to get a sense of what's going on in the decisional balance or the scale in someone's mind around the pros and cons of drinking. And it's really important to do this in 3 steps. The first is to give someone permission to say what the good things are about their drinking and asking them point blank. It gives them permission to say, I'm kind of shy and it's a social lubricant for me, or I've been really lonely since my husband died, and it helps with those, lonely nights in the apartment. The second side of that is asking about some of the not so good things. And it's important to avoid using the pejorative word bad here. We really don't want to attach labels to patients' behavior, and so we really stress that it's good to use this particular wording. And the third piece of this is to really reflect that back to the patient, again, with very careful word choice. And so the way that can be done is to say, so on the one hand, you're saying that it helps make you more comfortable in social situations. And on the other hand, your wife is nagging you and you're starting to gain some weight. Where does that leave you? And so it's really this act of reflecting that back to the patient and using the conjunction and, which we've underlined there. Again, we don't want to send an implicit value judgment by saying, so on the one hand you said X, but on the other hand you said Y, which clearly conveys our sense of which way we think the patient should weight the conversation. It's really important to turn it back over to the patient and let him or her start to figure out how to make some sense out of this potential decisional conflict in their mind. And step 4 is to, again, really leave this in the hands of the patient. So what's the next step here? What would work for you? What do you want to take? And it's important to start with the patient's idea and then to encourage some specificity. So some patients, for example, may say, well, I'm only going to drink on holidays. Okay, so let's talk a little bit about what holidays are coming up, because for some people, Super Bowl Sunday is a holiday. For other people, holidays just mean Christmas and Thanksgiving. So it's really important to be specific. Or I'm only going to drink with friends who drink less than me. Okay, so what friends do you think you'd go out with next time? And get them to really start to operationalize. I'm going to go out with Fred and Joe and Sam because they're the ones who have all cut back for health reasons too. It's important, though, as healthcare providers to reiterate your advice, which is to stick to those guidelines, and important to encourage them to follow up with a healthcare provider or with you in the future. I also, in conclusion, like to thank patients for being candid. They're typically not used to having this kind of conversation, and again, the idea is to create this safe space or stage for conversation. We have this really quick guide here that later on, when you're thinking more about how you can apply brief intervention to your own practice, the goal is to really match the conversation to what someone's readiness is. The conversation with someone who is a 1 or a 2 is going to be very different than the conversation you might have with someone who's a 7 or an 8. And you can see here the goals for the conversation based on what someone's readiness ruler score is, and you can see some sample questions that you might ask for someone who's at that level. But again, the goal here is to have this be a tailored, personalized conversation with that readiness ruler score really helping to drive and give you some guidelines about how to approach the conversation. Okay, what we would like to do next is demonstrate what brief intervention can look like. We would like to have you pull out your patient, the brief negotiated interview checklist, and we're going to ask you to listen along carefully while we go through a sample with Mr. Sawyer, again, but this time a different conversation, and we'd like for you to look for each of those key pieces of the steps that we just went through. Listen carefully for what the nurse does well and where there's some areas that could be polished up or that he or that the nurse practitioner could have done a little bit differently. And then we'll have some time to get your reactions about how you think this could be incorporated into your practice style. Okay, so Mr. Sawyer was admitted to the hospital for stage 3 chronic renal disease 2 days ago. His course was complicated by neuropathy in his lower extremities, especially in his feet, which is likely attributable to poor diabetes management. And he's mentioned previously to his physician during the H&P that he's a moderate drinker. He drinks 4 to 5 beers most evenings during dinner and while watching television, and approximately every other day. Oh, got ahead of myself.
So there we are, Lauren.
There we go. He drinks 4 to 5 beers, and approximately every other month he has up to 8 beers or mixed drinks when he's playing poker or watching sports at local bars or at the American Legion with his friends. He's never required a drink in the morning as an eye-opener, but his wife has been nagging him to cut down because he's been experiencing this neuropathy. But he's never tried to cut down previously. He's never had a DWI, and his drinking hasn't contributed to his work. He's a native to the Pittsburgh area. He's been married for 35 years. Has 2 adult children who live independently but visit often, and he's worked as a custodian for the Pittsburgh Public Schools. He's an avid Pittsburgh sports fan and poker player, and likes to spend time at the American Legion with friends to have a good time and ease his stress. He has a history of diabetes mellitus type 2, and he's aware that alcohol may contribute to diabetic complications. Diabetes runs in his family, and he has a cousin who he considers a hardcore alcoholic. As you listen to our scenario, please go through and check for each of the steps on the brief negotiated interview. So, Mr. Sawyer, as part of our standard admission assessment here in the hospital, we have questions related to health risks, like the use of alcohol, tobacco, and other drugs. And since alcohol use can affect different areas of health and also interfere with certain medications, it's important for us to know how much you usually drink and what your usual patterns are. So I need to ask you some questions about your use of alcoholic beverages during the past year. And by alcoholic beverages, I'm referring to beer, wine, liquor, etc. So in the past year, how often would you say you've had a drink containing alcohol?
Well, I guess I drink pretty much every night. I usually have a beer when I get home from work.
Okay. And then in the past year, how many drinks containing alcohol have you had on a typical day when you're drinking?
I would say 4, maybe 5 beers while I'm eating dinner, watching television. Yep, yeah, 5.
Okay. And in the past year, how often have you had 6 or more drinks on one occasion?
I don't know. I guess every other month when I go to the Legion to play poker or watch the game with my buddies. So I'd say less than monthly.
Okay, thanks for going through this. Let me see here. Based on your answers, you're saying that you drink most days during the week, and you have about 5 beers in the evening when you're watching TV and having dinner. And then every other month or so at the Legion when you're with your friends, you might have 6 or more. Does that sound about right?
Yeah, you captured that well.
Okay, so let's see. Let me add this up. Your alcohol screening score is a 7, which is considered a positive screen for alcohol use, or for unhealthy alcohol use. What we know is that drinking above certain levels can cause health problems or even make certain health conditions worse. Given your diabetes and your kidney problems, I am concerned about your use of alcohol.
You are? What are you talking about? I'm not that much of a drinker, really. It's just something I do to unwind. All right?
I know. It sounds like it's a part of how you unwind and relax with your friends. You know, a lot of people aren't aware of the recommended limits or how alcohol can affect your health. For men, it's recommended that you drink no more than 4 drinks at a given time and no more than 14 spread out over the course of the week. From your screening responses, it sounds like you're consuming about 5 drinks per day, so that would mean about 35 or so per week.
Yeah, I know it's not good for my sugar control. My wife says the same thing. Empty carb calories, weight gain, blah, blah, blah.
You know, even though it sounds like you've heard that before, I'm imagining that glucose and weight control are probably pretty important for you since you've had this new numbness in your feet. You know, decreasing or stopping alcohol consumption will also help slow some of that damage to your kidneys and help them function for a longer amount of time. What other kinds of links have you been making or thinking about between your drinking and your health?
Well, I don't know. My nurse practitioner once said something about high blood pressure in drinking and something about my arteries and causing my blood pressure to go up.
Yeah, that's true, and blood pressure control is also important for your kidney health. Have you ever thought about cutting back on your drinking?
Well, I'm not an alcoholic like my cousin. I've never had a DWI, and it's not like it's affecting my work or anything. I just like to have a few beers to relax. I don't see a problem with that. I work hard all day, and it's nice to come home and have a beer.
You work hard, and unwinding in the evening sounds like it's really important to you. Sounds like that's one of the positives of your drinking. Any others?
Well, yeah, it relaxes me in the evening. I have a few beers while I watch the game or when I'm out with the guys. It's just what we do together.
So it sounds like it helps you relax and socialize. What are some of the less good things about your drinking, maybe even the negatives?
Well, my wife keeps nagging me to stop drinking because she knows it's not good for my health, and it interacts with my blood pressure medicine. She wants me to quit, but I'm not going to stop drinking altogether. I think she just worries too much. Frankly, it's gotten pretty annoying. However, at the same time, if I can't walk, I can't work. I'm on my feet all day. I'm a custodian for the public schools.
So on the one hand, you said that drinking helps you relax and it helps relieve your stress. And on the other hand, you say that it might be making your diabetes worse and adding to the numbness issue and potentially being unable to work, and that it worries your wife and interferes with your medications. Sounds like there are some downsides too.
Well, yeah, but I didn't think only having 5 beers was considered that big a deal. I never considered that the numbness in my feet might be from drinking, and my kidney problems do scare the hell out of me. And, you know, my wife would like me to stop drinking, so now you're telling me I have to quit drinking too?
Yeah, Mr. Sawyer, with all of your health problems, that would probably be ideal, but reducing to the recommended limits could really decrease your risks and potentially impact your health in a positive way. You know, based on everything we've been talking about, how ready do you feel like you are to make some kind of a change in your drinking? Can you point here to this this scale where you are on readiness to change, where 0 means not at all ready to change your drinking, and 10 would mean already changing your drinking? What would you say?
So it's right here, a 4.
Okay, so almost halfway ready to make a change. What made you pick a 4 instead of a 2 or a 3?
Well, you know, I have been listening to what you had to say. Maybe I should cut back a little bit. I know that alcohol might be doing more harm than good with managing my diabetes, but you're asking a lot of me. I've been drinking like this for years. This is just what I do.
I know. It's not always easy to make changes to your lifestyle, but cutting back on your alcohol would be a good start. What do you think?
I don't know. But
yeah, I heard
well,
what you said. Sounds like you're a 4. It can be a difficult step.
Well, I guess I could start by trying to drink a couple drinks less each night. I could also drink more slowly, and it wouldn't be easy, though. I've never tried to cut down before. I'll have to think some more about trying to cut back.
That sounds like an initial plan. How many do you think you'd cut back to?
Well, I'd still have a couple beers to go with my dinner, but maybe less when I'm watching TV. I might be able to cut back to 4 a day max.
Mr. Sawyer, I think that cutting down from 5 a day to 4 would be a really good start in the right direction. What do you think? How do you think this fits in with where you see yourself down the road health-wise?
Well, I guess it would be healthier, and maybe my diabetes wouldn't bother me as much in the future. I could keep working. That's important to me, and maybe my wife would back off and quit worrying so much.
That sounds good. I have a booklet for you that I'd like to leave with you if it's okay. It's called Rethinking Drinking, and it has some information in it and can help you establish some little mini goals for yourself and has some ideas for troubleshooting if life starts to get in the way of you sticking to your plan. If you feel comfortable with it, I'd also like you to think about discussing your alcohol use with your PCP at your next follow-up visit when you're discharged. They can also help answer any questions that you might have about alcohol and how it connects with your diabetes and your medications, and then continuing to even cut back further.
All right, thanks. I don't know if I'm quite there yet, but I'm going to give it a try.
That's all that we can ask of you, just to think about it to get started. Only you can decide what's going to be right for you when the time is right to make some healthy changes. We've covered a lot today, but I do hope this helps you get started. I really appreciate your openness, and you've made some good initial first steps. Let me know if you have more questions while you're here. I'm going to go down the hall to get another patient ready for a CAT scan, but I'll be back to check on you in an hour or so, okay?
Yeah, that's fine. Thanks again.
So some of the things that we'd like, oh, I'm sorry, go ahead, Deb.
Well, I was just going to say that, that took about 7 or 8 minutes to go through that. So I think it's important to think in terms of how to build that into clinical practice and the routine practice of the nurse.
And some of the reflection.
Go ahead, Lauren.
Some of the reflection questions that we'd like for you to think about are how the nurse covered those 4 steps, how the nurse used a style that may be different from what we typically see in clinical practice in terms of addressing alcohol with someone, things that the nurse did well, things that could use some additional polish, and pieces of it that you might be willing or able to try to slowly incorporate into your practice. And we're also interested in your thoughts about stumbling blocks. Before we open up the chat box for responses to those questions or your reactions to the material that's been presented, we just want to draw your attention to some of the resources that we've mentioned in this webinar today. One is the NIAAA Clinician's Guide, which actually has some algorithms as well as those recommended limits. The Rethinking Drinking, getting ahead of myself. The Rethinking Drinking website as well as booklet, which has some really nice calculators on it. Material that's specific to youth and adolescents. And a position paper that was jointly issued by the International Nurses Society on Addiction and the Emergency Nurses Association in support of SBIRT. There are also references available through SAMHSA and also Boston University's Brief Negotiated Interview Art Institute. We have our contact information and are always happy to answer questions at any time, not just those that may be generated in the webinar, but also later on as you continue to kind of let some of this material marinate. Deb, what closing comments do you have before we open up for questions?
So I would just reiterate that you and I are both very happy to answer questions, so feel free to send us an email. Our agenda is really to help to promote this widely through the nursing community. So Tracy, we'll turn it over to you.
Great. Thank you for such a wonderful presentation. People really have enjoyed the role plays. I mean, they were terrific. That really helps to get the feel and the intonation and the voice and kind of the back and forth. It gives you a real flavor of when it's not done very well and when it's done well. And so I think that's really critical when people are learning, and it's nice to have that aspect here today on the webinar. We have a few questions that I want to, we probably have a couple of minutes for a couple of them, and perhaps we'll share some of them with Deb and Lauren, and if there's something that they can follow up with, if you want to email them directly your questions also, you can do that as well. But certainly if we can get them answered, we will try to do that. One of the questions we have here is, what if the patient says, no, I don't want to talk about my alcohol use? Deb, any thoughts on that?
I'll take that one because that one happened a couple times to me when I was at University of Maryland in the inpatient setting. Honestly and truly, it happens rarely, and basically what I do is reiterate back to them and say, so it sounds like this isn't a good time, and it sounds like it's something that you're not comfortable talking about now. Would later be an okay time? And then if they say, no, I really don't want to talk about it at all, you can say, so it sounds like if you were to rate that on a 0 to 10 scale, you're a 0. And sometimes they'll say yes, and sometimes they'll say no, I'd probably be a 1 or a 2. And then you can say, is it okay if we come back and talk about that later? Obviously, that's easier to do in an inpatient care setting or on another visit. But it is really important to meet the person where they are, so to speak. I think part of the rub becomes when we do have forms to fill out or assessments to get through, or we can't get on the next stage on the EMR, it becomes, we feel that pressure. But patients do have the right to refuse. Very often, that's why I can't overstate the importance of really establishing that initial rapport. It's really, really important. And I have truly found that 99% of the time, people are receptive to that. They see asking about alcohol use as a legitimate part of the nursing role. Most people are concerned about damaging the patient-provider relationship. That's the biggest concern as to why clinicians say they don't want to touch this issue with a 10-foot pole. Some of my research, as well as that of Miller, as well as Carol Shermer in the trauma unit, overwhelmingly shows that patients find alcohol screening and intervention by nurses or physicians to be acceptable to them. I can send anyone who's interested links to the survey that we did with over 350 veterans asking their opinions about the acceptability of different alcohol screening, brief intervention, and referral to treatment tasks. Patients see it as a legitimate part of our role, and so I would really encourage you that it's not quite as much of a barrier as you might think when you approach it in this patient-centered manner. Deb, what would you add to that?
Well, so I would really add and reinforce the importance of respecting that no, that is the patient's choice, and to say, another response is that I respect that you don't want to talk about it at this point. I want to let you know that at any point along the way, I'm more than happy to have that conversation with you. And I think if that comes back to building that therapeutic alliance and keeping that door open so that that even may help them to thaw and say, well, all right, let's ask the questions now.
That's great. Thank you. That actually answered several other questions about rapport and that alliance and having the conversation and making folks feel more comfortable. So you actually were able to answer several other questions about the importance of that. So I really appreciate a very thorough conversation about that because it seems to be something that's really important to the folks that are on the webinar listening in. So thank you. I think what we'll do now is we are at time to close the webinar today, but there are a couple of important things I want to point out. But first, I want to thank our presenters. This has been an exceptional presentation, something we've been looking forward to for many, many months. Having something that speaks directly to nurses from your experience on the ground, both clinically and from a research perspective, it's just very unique, and I think it really helps the nurses get something that's very tailored for them, and I can tell folks are very appreciative of your time and of your expertise, so thank you very much. And I want to just point out a couple of things that I think folks will be interested in, particularly around the materials. Again, all the materials are posted up at the hospital SBIRT.webs.com website, and there's the web address for you. The archived recording will be there, and you'll be receiving a follow-up email from us. A couple things that are really important. I know you're going to be wanting the CEs, and we also really need to continue our commitment to evaluating the kinds of education that we provide. There's going to be a link that I believe Misty may have may have already posted it in the chat box. It's a survey to an evaluation, and I cannot stress how important it is for us to be able to maintain this kind of education by having you complete that very, very brief survey or evaluation that is critical to our funding and to making sure we're providing you with the kinds of quality education that you have come to expect from us and all the partners. And you will get a follow-up email that will remind you of that, but certainly if you have a moment right now to take and link to that survey, that would be great. Please check our website too. You'll have links for the continuing education that are there, and again, the list of all the webinars and registration information. And in addition, I mentioned the CE information will be posted on the website as well. You get the 1.5 free CEs from NADAC, NBCC, American Probation and Parole Association, also accepted by OASIS, and that will be posted. So if you're looking for those, go in through that link. If you're looking for the nursing credits, you would go in through that link, and that would take you through the process of getting the certificate and getting your education credits and paying for those, which are $10. And I've mentioned this, we encourage you to come back and join us for these other very exciting and very current topics about how SBIRT is being applied into a range of settings. So we encourage you to come back and join us frequently, and we'll continue to bring you as many free continuing education credits as we possibly can, and to try to meet the needs of all of you who are really working in practice settings and doing research, and this is really state-of-the-art current information, so we'll keep doing that. So let me thank you all again for attending, thank our partners, all of them who come together to make this kind of quality education available. I hope that you've enjoyed today's webinar, and we look forward to having you in future webinars.
Thank you, Tracy.